And Stephen Derudi, who's the medical director, is sitting here in the room too. He doesn't swear, so we'll be okay. But we're going to listen in on a talk from Nick, and he'll introduce what the talk is about. But in essence, you probably all know that we've been fighting rearguard action on cancer in London for the last 10 or 12 weeks, and the Princess Grace has been involved heavily in that bit of work, and Nick at the forefront of that, helping to develop the service, run the service, and then begin to critically look at some of the data. And we thought we'd pull some early data, as much to critique the database as anything else. So today, I'm glad you're all online, because what I really want is a bit of critique before we delve into the 300, 400, 500 patients that we will have by the end of this. What we hope to have is a strong database and a good story informed by science. So without further ado, I'll hand over to Nick.
Thank you very much. Morning, everyone, and thank you for having me. I really appreciate your time. And as I say, the feedback that we're hoping to get today will be really integral to making sure that what we're doing here is really underpinned by some very robust methods and the appropriate analyses to really capture what success looks like here. Perhaps let me hide my face and share my screen with the slide deck that I have running in the background. Forgive me 1 second while I just bring that to the fore. Is everyone able to see that? Is that working?
Yeah, yeah, it's good. Thanks, Nick.
Wonderful. I'm seeing some nods. Thank you. Some of your faces familiar as colleagues working on site as well. The narrative, I think, is familiar to everyone who's been practicing clinically within the last few months since the beginning of the new year. But just to summarize the salient points for now, we had the COVID-19 pandemic declared as a level 4 national incident at the end of January. NHS England published its response and its next steps to accommodate the projected pandemic emergency admissions in mid-March, with a plan for all non-urgent elective operations to be postponed at the latest by the 15th of April, with a goal, as I said, to expand critical care capacity and to accommodate the projected surge of admissions. In parallel, the process that we saw was that urgent cancer treatments and essential care was prioritised. There was a balance of risks between for decision-making, both for patients and for their clinicians, as to whether to proceed with cancer treatment, cancer care, the balance of risk being whether it was riskier to undergo or to postpone treatment at that time. Where treatment was indicated to involve cancer surgery, consideration was given for coordinating cancer surgery within regional hubs that would accept referrals from NHS hospitals and consolidate the actual delivery of surgery on these regional COVID-free sites, of which the Princess Grace was one. And as I say, this was a question of balancing risks. The risk that was forefront in most practitioners' minds were the early reports from Wuhan province in China regarding the outcomes for perioperative patients, albeit a small sample of 34 who incidentally had contracted COVID-19 during the course of their planned surgery. And as you can see, the mortality rate was 24.5%. So this was really cause for concern. We therefore acted as one of London's 3 regional hubs. The Princess Grace Hospital offering 120 beds, 9 with level 3 critical care capability. And we pursued a perioperative medicine model implemented to at least deliver outcomes with the intention of delivering outcomes equal to those that were achieved pre-pandemic, and with an aspirational goal of improving on those outcomes. So the process began with the decision in the regional hub as to whether surgery would proceed. We had 10 NHS hospitals with their surgeons bringing their cases to this hub with discussions around their MDT outcomes, their most recent imaging, their most recent histopathology, the conversations as to whether to proceed to surgery or not, going from there. And then beyond the approval at hub, the end-to-end pathway was then shared collaboratively between the NHS surgeon and our intensivists in-house at the Princess Grace. For all other end-to-end, pre-admission to post-discharge pathway, we collaboratively worked on site to ensure that our processes were streamlined, protocolized, standardized, and that includes our admissions procedures, our inpatient review procedures, and our discharge processes. And it really was a collaborative effort, as I hope those of my colleagues on the call today can attest. It really broke down a lot of the barriers that, for whatever reason, have historically existed in all healthcare settings. I think faces became far more familiar, and discussions around patients prospectively predicting risks and certainly responding to any emerging complications really became a much more comfortable process with outcomes, as I will go on to discuss. The infection control processes that we observed on site were intentionally rigorous. We required patients to self-isolate for 14 days. We screened their exposure and their symptoms by telephone prior to admission. We admitted them to isolated rooms and they arrived on site via private transport. They were reviewed on arrival by one of the Clarking resident doctors. Blood testing was performed and these results were reviewed. And PCR swabbing, albeit we know an imprecise offer available at the time, was performed. And these results, the outcome of the Clarking as well for any signs or symptoms, this was all consolidated and appraised with a view to really understanding whether patients were still fit for surgery and fit for admission. We ensured that if there were any concerns about a patient's status, we had a separate isolation area where patients could be transferred for further investigation, further management, stabilization if necessary. If patients were fully well, they were and confirmed COVID positive or had a high index of suspicion for COVID, then we asked them to return home. They didn't undergo surgery at that point, with a plan to reschedule them in due course and a safety net for them to attend their referring NHS hospital in the event that they did become unwell. Any patients who were unwell at any point during this process, we also had a discussion with their NHS hospitals. Unwell, I should clarify, with regards to a suspicion for COVID. The remainder of the patients proceeded to surgery, and as I've mentioned, difficult as it was to maintain this requirement through conversation with our patients, there were no visitors permitted on site. Post-operatively, after surgery performed by a dual consultant operating team using open techniques to again minimize the risk of viral transmission between patient and operating clinicians, patients were transferred from recovery to our post-anesthesia care unit, which comprised 9 beds with level 3 capability, including multi-organ support, with trained critical care staff at a maximum of 1 to 2 nurse to patient ratio. However, if the patients were considered lower risk and clinically stable on a basis of their pathology, their procedure, their preoperative baseline, they were then transferred directly to what we termed a step-down unit, which was co-located with PACU, had trained staff at a maximum 1 to 3 nurse-patient ratio, but it was designed as a single directional flow through from PACU. So patients would progress via PACU if necessary, but as I've said, according to the lower risk or clinically stable criteria, otherwise directly to step down for stabilization post-operatively and then transferred to the ward when appropriate. And both areas, and indeed the wards beyond that point, observed enhanced recovery pathways with twice daily surgical and perioperative medical ward rounds. The patients proceeded in this single direction through the pathway to discharge, whereupon they isolated again for 14 days post-discharge. And then we had a process of follow-up really built in as part of our core service offering, which was immediately in the first 1 to 2 days performed by a nurse specialist to detect any concerning symptoms. And as I'll describe, that really was a very valuable safety net to ensure the safety of our patients. Then at day 14 and day 30, we had follow-up calls, telephone calls, performed by GPs who were working with us, having had their original primary care settings temporarily decommissioned during the pandemic. So they joined us and we utilised their communication skills and their recognition of patient presentations in the community. So this, we felt, facilitated a very high standard of care and a safe method by which we could deliver major cancer surgery in this pandemic, excuse me. And as you'll see, I'll present the first 100 patients now. Of this first 100 patients, 88 proceeded to surgery, 78 proceeded immediately, 10 were initially rescheduled as a product of the steps that I've described. 3 of the 10 were demonstrated COVID positive on admission, so they were rescheduled. On 2 occasions, the surgeon who was due to perform the operation was themselves proven COVID positive. Fortunately, was fine, but the surgery was rescheduled again. On occasions, to avoid overburdening the system, we decided that PACU was running at capacity. So for 2 patients, surgery was rescheduled, and the patient, having confirmed that the patients were stable and well for this decision making. And on 3 occasions, unfortunately, the data was not available to confirm why it was rescheduled. 11, conversely, did not proceed to surgery, rescheduled, as I've shown here, beyond the time span for this first 100 patients. So actually, within this cohort, we are talking of who did not proceed to surgery initially. A further 8 did in time receive surgery, just not within the time span of this current cohort analysis. 5 of those rescheduled because they were COVID positive. 2 actually had surgery in the NHS, and 1 was unwell on admission but subsequently returned. And 4 planned procedures were cancelled. 3 because unfortunately at the time of presentation the patients were deemed to be newly inoperable, and on 1 occasion a patient self-discharged. So let me bring my next slide here. It's the data table that we are in the process of publishing, which demonstrates, I would hope, the demographics, the distribution of our 88 patients who proceeded to surgery here on site. As you can see, this splits according to, of 88 total who proceeded to surgery, 46 were colorectal specialty patients, 26 were HPV patients, 15 were head and neck. And you will note that only totals 87, because in the bottom right, you will see there was 1 upper GI surgery that was not included in this table, was a comparatively lower risk procedure and had a grade 1 complication and unfortunately was lost to follow-up. Otherwise, of our 88, you'll see the median age was 62. There was a reasonably even split of sex of the patients. 48 were female, 40 were male. And these were patients referred in from hospitals in the north and the east of London. And particularly in the east of London, we recognised that these were patients with a large number of comorbidities. They were comparatively more complex a point more acute than our previous surgical cohort that in the pre-pandemic era in the private sector we had typically managed. This was an unselected take, and so using ASA classification as a marker of their comorbidities, you'll see that ASA2, 53 of the 88 were represented there, and 26 had an ASA of 3. So in the overall, this led us to a mortality risk projection, P-possum median of 2.1% mortality. And that, I think that reflects the fact that 80 of our patients did proceed postoperatively to PACU. 8 were deemed lower risk and clinically stable and eligible for step down. There was a median length of stay on PACU of only 24 hours. And then in total, end to end, this is from admission to discharge, 8 days in total, which we felt, as I'll go on to say, was comparable with the pre-pandemic outcomes that we feel have been achieved globally and external to this site. We used the Clavien-Dindo classification to recognize our surgical complications. 68 patients had a grade 1 complication. Now, if you total up all of the surgical complications, you'll note this does equal 88. All of the major surgeries required at least support that scores a grade 1 complication on Clavien-Dindo classification. So therefore, we proceeded to adopt the PQIP approach, which is to use the grade 2 and above complications to denote major morbidity. And of these, there were 20 patients of the 88 that had a major complication. The flow post-discharge achieved 81 of the 88 followed up at day 14 and day 30. Which represents 5 patients who were lost to follow-up. And there were 4 patients who were acutely readmitted to hospital. And again, if you look to the bottom right, you'll see that of these, 1 was readmitted with a PE secondary to a DVT, 1 patient had ileus, 1 had a wound infection, and 1 had pain that was not adequately controlled. But what you will notice that we are proud of is that there were no cases of nosocomial transmission detected, no suspected or confirmed COVID once we'd passed the initial checkpoint of our admissions processes. So this, as I've said, represents an overall major morbidity of 22.73%. Equating to 20 of the 88 patients with a Clavien-Dindo score of 2 or above, or overall mortality is 2 of the 88, which corresponds to 2.27%. I've now translated those results that we achieved to the top right for reference. Again, referring to the PQIP report from 2019, the major morbidity that we achieved is broadly consistent, given our limited sample, with the 17.2 to 18.7 major morbidity achieved in a comparable cohort of procedures, of specialties. And we also, for our mortality comparator, referred to the ISOS International Surgical Outcomes Study, which in high-income settings, such as ours, post-complication mortality was 2.6%. The other key comparator that was published since we proceeded along this pathway was the 1,100 patients who were accumulated via a surgical trainee collaborative, termed the COVID Surge Collaborative, published in the Lancet in, I think, May, late May. And this was a study of perioperative mortality in COVID-19 patients, representing 235 hospitals from 24 countries. So not all of these were comparable settings in terms of income. but all patients undergoing surgery with SARS-CoV-2 infection confirmed within 77 days preoperatively or 30 days postoperatively. And you'll see that the mortality rates reflected in this cohort following elective surgery were 18.8%, following major surgery were 26.9%, and overall were 23.8%. So it wasn't possible to derive from that paper the comparable population directly to set against ours in terms of the mortality rate. But if we assumed that our mortality was 2.27% in this early cohort, and our patients having been undergoing surgery globally in a setting that had not been able to control its exposure to the pandemic, the mortality would have been between 18.8 and 26.9% mortality. So we were, I think rightly, feeling quite proud of the system that we put in place to keep our patients safe. That concludes the data and the processes that I was looking to discuss with you. As I said, I would really value any observations, further questions, and recommendations for how we could tighten our approach, either in terms of the pathways that we've implemented or the analyses that we're looking to use going forward. I will say that clearly with the caveats that this is not a full cohort of patients who have completed 30-day follow-up yet, and this data is 1 week out of date because I've just returned from a week of leave. But at the point where I left last week, the week prior to, sorry, we had 3 recorded deaths from a total population of approximately 500 patients who have undergone surgery here, which would correspond to a 0.6% mortality rate, which, given the pre-pandemic outcomes that we've referred to, and particularly the challenges associated with delivering surgery at this time, we felt really was some cause for celebration. So it's something that we're quite keen to analyse and really unpick the methods by which these results were achieved going forward. Thank you very much.